Welcome back to Inclusion Revolution here on Eastlink TV. I'm Tova Sherman, your host, and again we're welcoming back Dr. Ahmed, and the discussion today is the spectrum of disorders around ADHD. Now, when we just broke, Dr. Ahmed was telling us a lot about some of the ways we can identify whether or not our child or someone we know is displaying some of those characteristics, and one of the best ways I heard was by journaling, and also something that Dr. Ahmed has shared with me on the regular I think is really interesting as well, is the genetic connection. Yes. I find with a lot of disabilities we hear more and more, doctor, about the genetic connection. Yes. And I know with my clients who have identified as being ADHD, I have had the experience of meeting a number of the parents and seeing what I believe to be some of those characteristics as well. Yes. So I can see why the journal can be beneficial not only for the child, but perhaps for the parent who's experiencing it. Yes. But let's make the assumption, doctor, they've gone to the doctor, the doctor has said, the GP usually, because that's where we start, and the GP has said, I believe this is ADHD. Mm-hmm. Now, as an expert yourself, do you find that the GP I don't want to say usually right, because you're not statistically aware of that one way or the other, but in your experience, have you been seeing GPs even referring people and saying ADHD or spectrum of, and you identify that, although I can understand why they thought that that wasn't really the case? I mean, do you experience that as well? Or not so much?
There are times when I've experienced that. In fact, it can be very disconcerting when a child, for example, with bipolar disorder or childhood psychosis, which was called schizophrenia in the past, is diagnosed and started stimulant treatment with ADD. That is dangerous because it can lead to more psychotic episodes. And once a person has a psychotic episode, then it's very difficult to manage the psychosis.
Understood.
So we have to be very careful, and as I said previously, that it's a diagnosis of exclusion. So if a child is hyperactive or is not attentive in school, I think what's important, and of course the family doctor may not have that time, but I always encourage them and say, make a repeated appointment. Make a repeated appointment every 4 days or 3 days. Finish this history. Talk to the school. Talk to the parent. The more collateral information you have, the more correct your diagnosis is.
And you know, when you said that to me, it was really struck, because I have to be honest, in the first segment when we were talking, I was thinking a lot about mental health in youth and how some of these behaviors were very much can be confused with early onset, as you said, psychosis or bipolar disorder. So I really heard that, and I guess that's a great fear for all of us, is the right diagnosis, and that's why we lean on our JPs. We don't always get to the specialists like you right away.
Yeah. The other thing that is very common, I'll just talk briefly about that, is the comorbidity with ADHD. ADHD is a very comorbid, and comorbid simply means what other issues do I have? Okay, so I could have learning disability, I could have obsessive compulsive disorder patients, I could have social anxiety, which is extremely common comorbid situation with ADD. I could have learning disability in math and language. I could have a psychotic child with a family history of bipolar disorder or schizophrenia. So I have to be careful when I'm diagnosing, what else have I left out? Okay? What is the environment of this child? How is the family functioning? What is the elements around there that this child is bringing to school or bringing to play school or bringing to a social engagement, right?
So you're doing a very holistic approach, and you have to, because as you've identified, if misdiagnosis can be dangerous, not just, you know, slowing down the process, but actually dangerous. And that's something that, so you're taking this very holistic look at the lifestyle, the family, the situation, and then so you've identified, let's presume that this child or young person does in fact live with ADHD or in that spectrum disorder. Now what does a parent do? Or that person do, because often it's an individual as a young adult.
If a diagnosis is accurate, then what I usually suggest is a liaison of management. If a child is purely ADHD, pure ADHD exists in only 35% of diagnosed ADHDs. There is always a comorbid condition.
Understood.
General anxiety, social anxiety, mood disorder, depression in children.
I've rarely seen a person with any disability, quite frankly, doctor, that doesn't have a secondary, whether that was caused by or it just happens to be there, although they seem connected, especially around cognitive.
Yeah, exactly. So, you know, what we have to do is meet with the school, talk to the teachers, talk to the parent, talk to the play school teacher, get an idea of what is happening. If the child is inattentive because he has a learning disability or his IQ is poor, we should try and see if we can arrange a psychoeducational testing. We should be able to help him accommodate in school, provide accommodations in school, discuss with the school about IPP programs.
Right.
But the first thing before that is education. Educating the parent and the child. The child must know. There is no need to label a child because people don't really understand ADHD yet. And the way they understand it is very negatively.
Correct.
Oh, if I'm ADD, I'm a loser.
Yeah.
No, that's not true. ADD people have been president of countries.
That is correct.
They've been stars, they've been athletes, you know.
Very successful businessmen.
Successful. So what we need to do is have an idea that the child doesn't feel bad, that ADHD is a genetic condition, it is not your fault, you or your parents should not feel guilty about it. It's like diabetes or asthma. It is there, we have to manage it. So educate them, let them read so they can ask questions. Many times unanswered questions are dangerous.
Understood.
And people forget when they come to their doctor. They only have so much limited time. The second thing we tell patients is medication. Medication is considered, we have biases against managing ADHD with medication, but as you know, research indicates that untreated children have a lot more problems of school failures, substance abuse, loss of jobs, financial difficulties.
And it's really because of a lack of an equal playing field.
Exactly.
It's not because they live with ADHD.
Exactly.
And that's what Inclusion Revolution is about. We're determined to say this is not about somebody not being as good or capable. It's about understanding and then equalizing the playing field, whether that's a ramp for a wheelchair or perhaps more time or a quiet spot for someone with ADHD.
How do we accommodate this person? They can function very well. The point is lack of accommodation that leads to failures and lack of success. Then the third thing is teaching behavior modification. Some parents will not even agree with you that a 4-year or 5-year-old should be treated with chemicals.
Yes.
Okay? But you have to give that explanation, give them some research data, whatever we know, and say, look, these are the type of medications that exist now. These are safe. These are the issues that are serious with it. Let's discuss this. Make sure that the child is physically healthy. We do not medicate children with heart disease or conduction defects of the heart. Okay? We have to be careful because stimulants are like many cups of coffee. Yes. You're stimulating the dopamine, the chemical in the brain, which is called a chemical imbalance, ADHD. Well, it is an imbalance in a way, but at a very basic stage. So the dopamine has to move from the areas where it's blocked or not able to go. And that leads to symptoms of ADHD. So medications will allow that exit of dopamine to work, okay? And that is what happens. So medications for ADD over a period of time have been timed. Some medications last 4 hours, some last 8 hours. We've recently finished a research on an extended release medication in Canada, which is a prodrug, and that lasts 13 hours.
Now, I know you're very involved in drug testing and you're really on the cutting edge of research around this, and I'd like to talk a little bit about that more. So we're going to take a quick break. I'm so sorry, Dr. Ahmed, because it's fascinating, but we're going to take a quick break here on Inclusion Revolution on Eastlink TV, and we will be right back with Dr. Ahmed. Please join us.